Our next session will be moderated by Dr. Nancy Dickey. She is President Emeritus at Texas A&M University Health Science Center, and she is the Executive Director of the A&M Rural and Community Health Institute, and she will moderate the next session, The Science of Addiction and the Opioid Crisis. So, Dr. Dickey.
Thank you very much. Brett, thank you for setting that up for us. We appreciate it. The drug overdose numbers you've just heard, with over 70,000 deaths nationally, while overdose deaths per capita are relatively lower in Texas compared to other states, we still have thousands in Texas who are dying, and policymakers are exploring a proactive approach to the substance abuse crisis. This is a little bit of a turn in the road from the hard science, perhaps, that we've done most of the day. This panel is going to explore new approaches in pain management, addiction treatment, and community policies, as well as partnerships to combat the opioid crisis. I was going to say I'd like to invite the panelists up, but they're so compliant they're here, all right? So allow me to introduce them briefly, and then we'll ask each of them to make a short presentation. After all of the speakers have concluded, we're going to have some group discussion among the speakers, and then we'll open it up for questions from all of you. Our first speaker will be Dr. Carrie Byington, Vice Chancellor for Health Services at the Texas A&M University System. Dr. Byington is a pediatric infectious disease physician. Her commitment in her role at A&M is to transforming health professional education in ways that advance the health of the state, and opioids have been one of the ways that she has identified to try to move that bar. Following Dr. Byington, we'll have Dr. Theodore John Price, professor at the University of Texas at Dallas. Dr. Price is the director of Systems Neuroscience Program of Behavioral and Brain Sciences at UT Dallas. He's interested in molecular mechanisms driving transition to chronic pain, with a focus on drug development for chronic pain diagnosis and disease modification. And I'm looking forward to those comments, Dr. Price. And then finally, we have Umair Shah, the Executive Director of the Harris County Public Health. Under his leadership, Harris County, which is one of the largest counties in the country, has won numerous awards, including recognition as Local Health Department of the Year in 2016. Dr. Shah is known as an innovator and a public health leader, and is going to talk to us about what happens on a day-to-day basis. So allow me to invite Dr. Byington to start the panel.
Thank you so much, Nancy. And it's wonderful to be here. I'm so pleased to be at the meeting. I have just one slide, which, there it is, actually shows the Texas A&M Health Sciences Center Opioid Task Force and some of the activities that we've engaged in. I started this task force in January of 2018 as a way to begin to work across our colleges and disciplines. People ask me, why did you start the task force and why around opioids? You've heard Admiral Gerard's statistics, and this was a bellwether for us to come together. Texas A&M is a land-grant institution, and we have a special commitment to education and service across the state. We are also a research institution with almost $1 billion a year in research activity. And that research, there's a special emphasis on applied research and taking research from the university out into the community across Texas for those that we serve. And at this point in our history, the opioid epidemic is really a focal point for action. You heard that I was an infectious disease physician. As an infectious disease physician, this reminds me of the HIV pandemic in the 1980s and organizing around that to combat the pandemic. And so you've heard a lot of data about the opioid crisis. One of the pieces of data that impresses me the most is that the number of deaths that we have in the United States today are actually, and the age of the deaths that are occurring, actually are changing the life expectancy statistics in the United States. And we're seeing life expectancy in the US begin to go down now for the second year in a row. And so it was that perspective that caused us to form the Opioid Task Force. And our vision was really to improve the health of Texans by reducing the burdens associated with the opioid epidemic, and to do it through collaboration. I am a physician, and physicians are called upon to work in this field to prevent opioid misuse, to diagnose it, and to treat it. But the opioid epidemic is not principally a medical problem. This is a societal problem and touches us across many, many disciplines. So as we were forming the task force, we wanted to be interprofessional, to leverage the expertise of all of the health sciences colleges at Texas A&M, including dentistry, nursing, medicine, pharmacy, and public health, each with their own expertise and each with the ability to touch a different part of this problem. We also wanted the task force to be interdisciplinary. So we worked across the main campus, our colleagues in law, our colleagues in liberal arts, in education, and others, and with those in our community, government, law enforcement, K through 12 education. This touches all parts of our community. We wanted the task force to be inclusive, and so we address clinical care issues, education, research, advocacy, and public policy, and we welcome the input from all of those areas. And then finally, we are an incubator for ideas and an incubator for our students and trainees. We have started a student ambassador program, welcoming students from all of our different disciplines to work with us in their area of interest, be it clinical care delivery, research, education, or public policy and advocacy. One of the things that has gotten the most attention is our emphasis on naloxone training. So this is in my bag, and it's in the bag of many, many individuals at Texas A&M. We have made the commitment to train every health science student in the delivery of emergency naloxone. That is over 5,000 students that we will train this year. We are the first academic health center to make that commitment that this is part of everyone's education. In the same way that we learn CPR and other things, we're teaching them to use naloxone. We started this training program in July. We already have 5 lives that we know have been saved through this program. And it's an opportunity for us to serve our community and to serve our institution. So thank you very much for that moment of time. Thanks.
Good afternoon. Everybody. Oh, my microphone. Okay, so I'm Ted Price. It's my intro slide. You can go to the next slide, or maybe this will work. So I want to just talk briefly about 3 things. I'm going to tell you about the great strength we have in pain research in the state of Texas. I'm going to tell you about a specific project that has come out of a consortium we started called the Texas Pain Research Consortium. And I'm going to tell you a little bit about our entrepreneurial activities to try to take the discoveries we're making into the clinic. So as I said at the beginning, Texas has this amazing tradition of pain research. The reason for that is it all lies with one person, Dr. Bill Willis, who passed away a couple years ago. He started his career at UT Southwestern and then was the chair of anatomy and neurobiology at UTMB for a very, very long time. He was one of the godfathers of pain research, discovered many of the pain pathways that we teach our students in medical school, and began this great tradition of pain research in the state. In 2015, at a meeting at University of Texas at Dallas, we kind of formalized this great tradition into the Texas Pain Research Consortium. This is a group of investigators across the state. We run our individual research labs, but we've also started many collaborative projects. And we've been very successful in bringing pain research funding from the NIH to the state. Our most recent number that we have is 2017, 18.7 million in direct costs coming to the state for pain research. We have a meeting every other year. Our next one will be in 2019 in San Antonio. If you're interested in getting involved in this field, we don't have the date set. I can tell you it'll be in San Antonio for sure. Please come to the meeting. It's a very dynamic and vibrant meeting, and I've seen some people who are here at that meeting in the past. So one project that came out of this initial meeting is about RNA sequencing from human dorsal root ganglion neurons. This is the peripheral nervous system, not the central nervous system, but we know that chronic pain is driven by changes in neurons in the peripheral nervous system called nociceptors. They become hyperactive and start sending a signal to the brain even when there is no input. So this is a key driver of neuropathic pain, and again, there were a lot of talks about RNA sequencing this morning. We started a big project back then, taking human dorsal root ganglion neurons from patients that are having a surgery called a vertebrectomy that's done at MD Anderson. And this is a multifaceted project where we do electrophysiology and RNA sequencing and then try to integrate that data to understand what's happening to promote chronic pain in these people. And from that effort, we have identified many new targets. In particular, we have started to work with a pharmaceutical company called Effector Therapeutics that is in San Diego, California, that has a late-stage drug called EFT508 that's in development for cancer. We've now used this on these human dorsal root ganglion neurons that show spontaneous activity, which you can see here. These are just firing action potentials in the dish after they're taken from the donor. In this case, the donor is still alive. They're having a surgery to repair their spine, but the dorsal root ganglion comes out as part of the surgery, and this drug completely reverses that spontaneous activity. So we've also done a ton of testing now for this drug in preclinical pain models. It shows quite remarkable results, and we're very interested now in trying to repurpose this cancer therapeutic that's under development as a potential chronic pain medicine. It's non-opioid, and we think would be non-addicting, and it targets the peripheral nervous system, not the central nervous system. So in that kind of spirit of taking our discoveries and moving them towards the clinic, just want to mention a company that we started at University of Texas at Dallas, myself and Greg Dusor and Lucas Rodriguez, who's in the middle. He's the CEO of this company called Circi Therapeutics. He started with us in developing this company when he was a Ph.D. student in bioengineering at UTD. This company is developing a non-opioid acute pain medicine. So the idea of this is to replace the need to use opioids for minimally invasive surgeries. And Lucas has now raised around $20 million to get us through phase 2, and this drug is getting dangerously close to starting clinical trials in people. So that, I hope, gives you just a flavor of the kind of work that's happening in the state to make discoveries to try to make better acute and chronic pain medicines. Thank you.
Well, thank you for having me this afternoon. My name is Umair Shah, and I'm Executive Director of Harris County Public Health, the County Health Department in Houston, Texas. And so I'm going to do my best to try to, as opposed to my colleagues who have like 1 or 2 slides, I have like 45. So I'm going to do everything I can in about five minutes here. But I really want to just describe really what happens from that population health perspective, and so that's really what public health is all about. And so as Dr. Girard, who has always done an incredible job representing Texas, but specifically on this issue, has described, this is a national and also global phenomenon, and without going into all the statistics that he went into, just to recognize that it is not just a statistical issue. This is a human being, a matter of personal lives that's really a part of this. It's no different in Texas. In Texas, as you know, that the opioid crisis has not been given that level of attention necessarily, or the thought being that it is as severe of an issue based on data points when you compare it to other states. My home state of Ohio, for example, or West Virginia, other states like Indiana, where there's really an incredible epidemic happening. But I would really dare say that I would ask us not to feel comforted by that, in that, oh, it's not a problem in Texas. It's that our data points may not be as robust. And so we have really a data issue as well in the state from a population health perspective. And so Harris County is big, diverse, and complex, as just mentioned. We are the third largest county in the U.S. with 4.7 million people, which would rank us between Kentucky and Oregon, somewhere between Kentucky and Oregon, number 25, 27 as a state by population. And we are spread over the size of Rhode Island. So if that gives you a little bit of scope for us. And it's always good to just take a moment to step back and talk about public health. So a lot of people get confused about what is public health, right? We think about tuberculosis care, we think about what's happening in the safety net system. What I like to really say is that public health is the offensive line of a football team. And what healthcare delivery and science and all the things that happen within a health system or hospital system is very much about the quarterback. We are the offensive line. We are the ones that are sweating and blocking and all sorts of things. Unfortunately, our Texans didn't do very well. Everybody knows Deshaun Watson, number 4, but nobody knows who number 68 is. And the poor guy's been playing the entire game. And so I think it's really important to remember that we have this hashtag invisibility crisis in really public health. There's also this real concept of social determinants of health that Dr. Giroir had mentioned, which you can see here, a physician out of San Francisco who said, I diagnosed abdominal pain when the real problem was hunger. And really thinking about, I confuse social issues with medical problems in other patients too, and just really going on to say that the medical education doesn't prepare us for what we see out in the world, because it's really about health happens not just in the healthcare system, but it happens in the community where we live, learn, work, worship, and play, and that's where public health comes in. I'm going to skip this to just say we have a formula for what we really describe as innovation, engagement, and equity, our cornerstone values, which are very important in taking on anything like substance abuse, innovation, engagement, and equity. But it really comes back to data. And so in Harris County, we have multiple drugs as being the issue. And as you can see, our large county is spread out with various factors throughout the county. And so there are certain areas that are accentuated where we have problems, but it really is a community-wide issue in some sense of the word, and multiple drugs is really the name of the game in Harris County. And so some of the data here just show that it, again, you see prescription opioids in the top curve sort of coming down as we've had a little bit more handle on physicians doing some of the prescribing as opposed to mid-level providers, but you still have an incredible amount of work that needs to be done in our community. And you see the curve on the right, or the graph on the right, that shows that opioids are a significant problem, even compared to ethanol, which obviously is what we oftentimes think about. So our response is very much taking this 3 C's of capacity building, whether internally or externally, but also thinking about collaborative planning and programming, and really working with our legislative bodies and our political bodies. As you know, the legislative session has now begun, and that's very important for us as we think about the kinds of things that we do with our stakeholders, not just our elected officials like schools, but other stakeholders as well, like schools and curricula changes, so that people really have a better idea about social and environmental change. And finally, community engagement, and really working with our providers and our hospital systems, but our community, to get the word out about the real scourge of what's going on with this challenge. When Harris County has about 20% of the population of the state, actually less than 20%, and we have just about 20% of the mortality from opioids, that is a significant problem that we have in our community. And let me close by saying that opioids really a local problem that really needs local solutions, local data, local funding, and really local seat at the table, and making sure that public health is a part of that seat, and really ensuring that we invest in public health, which oftentimes doesn't happen because we think about the quarterback. We don't think about the offensive line that needs to be invested in, and it's really important for us to remember that local public health just makes common sense. And that's a picture of me when I had hair, and it was, thank you, and it was black, not gray, during Hurricane Katrina response in the middle of the night at 2 o'clock in the morning when I put an official form in for common sense, not new widgets and tools. And I think that stayed with me, that we need common sense, but it takes a village for all of us to work together. So thank you. I look forward to the questions.
Well, we've heard from a clinician, from a bench scientist, and from a public health specialist. And I think it's fair to say we all agree we have a major problem, but we don't have the right solution out there yet. So let me, is Dr. Joie still here? Hopefully he's listening. Lots of good ideas being propagated, but many say there is inadequate funding to actually see if any of these solutions are going to come to fruition. So if you could access the billions that Dr. Joie says are out there, what one project, what one goal would you ask that CMS spend those billions, or that Congress would legislate for us? So each of you pick one of those and tell us why you think that might begin to have an impact.
I will go ahead and start. It's hard to pick one. I actually have two that I think are really, really important. First is education to providers in being able to limit opioid prescribing for acute pain. We know that 70% of opioids are prescribed for acute pain, and we know from data generated by the CDC that every day you take opioids after day 4, your risk of continuing to take them a year, 3 years, 5 years later goes up. And it's staggering. As many as 25% may still be taking opioids in 3 years after having received only 4 days worth. So if we can educate and train prescribers, that would be really important. We're going to be doing it through something called Project Echo. The second thing is I'm teaching my students how to use naloxone. But when the person survives this overdose reversal, I need a place for them to go to receive treatment. And that's the next big thing that I would try to invest dollars in. So preventing the problem, hopefully from the very beginning, and then being able to adequately address the problem that's once it's been diagnosed.
Dr. Price?
It's a great question. I think that the state of affairs in treating chronic pain is really far worse than people appreciate. The drugs that we have really are not effective in the vast majority of patients. And I think that the funding response to the HEAL initiative is actually tremendous, so I have no complaints about that. I think that the federal government has done an outstanding job of responding in terms of getting money available for people to do development. And I would like to see a little bit more focus maybe on helping academics to turn their discoveries into innovations that can actually make it to the marketplace. So one kind of really practical thing that I've been talking about as much as I can is that the time frame for drug development for phase 1 SBIRs is impossibly short. You can't hire somebody in the amount of time that you have, much less do the work. And I think that some really practical changes could help academics tremendously in being innovative about taking the technologies that they're developing towards the marketplace.
Hope you'll share that one with Brett. It sounds like he might be able to help us out. Dr. Shah?
Yeah, I would just echo what my colleagues have said. And what I would also say is that this real importance of raising the intersection point of healthcare delivery and public health really coming together, that's absolutely critical. So anything the federal government or others can do to raise the visibility of that commonality, that there is such an important piece here, that we do talk a lot of times about healthcare delivery, and I completely agree with Dr. Price as he was mentioning about opioids and mental health and this challenge about addiction. We've got a real problem in this country when it comes to thinking about chronic disease and chronic disease prevention, and yet mental health doesn't appear to be in that. It's almost siloed out. And what we do oftentimes we talk about, and there's still not as much stigma when it comes to diabetes and heart disease and obesity and all these other areas that are physical ailments in some sense. And yet when we come back and talk about mental health or addiction, these are still chronic conditions that have many acute manifestations, and yet we don't treat them that way at all. And that's a big problem. And so when we silo things out, that's a challenge. So I would say it's a twofer. It's this public health healthcare delivery, but it's also think about this mental health and addiction in a more chronic way and not just in an acute way that we oftentimes do.
Yeah, just follow up on that. I really appreciate your comments about the siloing of mental health. In dealing with young students, those in the health professions, you can see a generational switch. They're definitely more willing to talk about these issues and to see the integration. And one of the reasons we have our Student Ambassador program is to try to reduce the stigma that already exists. And I've had a number of conversations with students who, as they begin to learn the science of addiction, replace an idea that this is somehow a failure of will, a failure of human will that has allowed a person to become addicted to medication, but rather that this is a disease state and we need to treat it as a disease state. So anything that we can do to eliminate that stigma and to increase the availability of mental health services will go a long way in this epidemic.
So, Dr. Price, if I understood some of your material, there's some of us, not all of us, who may, in fact, once the nociceptors begin kicking in, seem to convert to a chronic pain syndrome. Or do we all do that?
So this is really an area that's progressing really rapidly within the field. So there have been a number of recent studies that there have been kind of competing ideas about what is the driver of chronic pain. And there's been this idea of this concept called central sensitization that comes from the work of Clifford Wolff in the early 1980s and has turned into kind of a way to describe chronic pain patients and this idea that chronic pain can have a CNS generator. Mm-hmm. And that now has been tested by a variety of different groups in some fairly large clinical trials that have shown that if you can find where the generator of the pain is coming from and give a nerve block, the pain almost always goes away, which demonstrates, I think, that you really have to have a peripheral driver even for extraordinarily chronic forms of neuropathic pain, including phantom limb pain, which there's a kind of pervasive idea that is actually a centralized form of pain. So that doesn't mean that plasticity in the nervous system doesn't play a key role. It just means, plasticity is about amplifying signals. If there's no signal to begin with, there's not a signal to amplify. So I think that has refocused to some extent the field on this idea that we can reverse pain at its source. And in so doing, we can create non-opioid or potentially not other forms of pain medicines that will not be addicting because they avoid targeting the central nervous system. There's a tremendous amount of redundancy, unfortunately, in the endogenous pain alleviating areas, which is primarily the periaqueductal gray, and the same receptors are found in the nucleus accumbens that drives reward. So it may be possible that you can specifically target these endogenous analgesic centers with new types of drugs and not also engage the reward circuitry. But the more we learn about this, the more congruent those systems seem. So it seems that could be very difficult to do. So I think there's tremendous opportunity in going back to kind of this original idea of how pain becomes chronic and targeting the peripheral nervous system. And that's kind of what the goal of this sequencing project that started here in Texas is really aimed at. We're sequencing peripheral nervous system tissues from people that are otherwise normal. They're not normal because they have to have this major surgery, but they have no signs of neuropathic pain, and others that have very clear neuropathic pain. And we're learning a tremendous amount about why those neurons seem to completely reset their excitability and fire action potentials all the time. And I just showed you one example of a drug that reverses that quite readily that could be tried in clinical trials. But there are other investigators working on this project that have found other mechanisms through which that can be done.
So Dr. Byington talked about trying to begin to change the mindset a bit so our students don't think of pain or some of the social issues as a matter of will, but rather something that our patients struggle with. How do we, we can teach that to the students perhaps, although my guess is that's an uphill battle once they leave education and move out into society, but how do we do that for society? Because in fact, that's part of the reason we have a parity issue, isn't it? If you didn't bring these problems on yourself, then we wouldn't have to worry about treating your depression or your chronic pain or whatever it is. So how do we begin to turn around the environment in which we're trying to solve the problem?
Yeah, it's tough. There's no doubt about it. We found this both in various emergencies that come up. Obviously, Hurricane Harvey that hit the Texas coast, and Harris County was significantly impacted, but also during Zika. I mean, Zika was a prime example where you had a threat to pregnant women from a first-time ever mosquito-borne disease, and we raised awareness, but raising awareness is a very different science than changing behavior, right? So it's one thing to say, here you've got pots of water in your yard, and you know it's a breeding ground for mosquitoes, but I need you to go out and actually dump those pots of water so you protect the woman 3 or 4 homes down. We had trouble getting that message, not the message out, but getting that message to the point of behavior change. So now you add in something like opioids, prescriptions, a very complicated healthcare patient dynamic, and in addition to that, the stigma piece that comes in, and it becomes a really challenging element. But I think what, as I mentioned at the very end, is that it really does take a village. It takes all of us. I mean, at the end of the day, it is researchers coming together with the best science, the pharmaceutical solutions in many ways, whether it's medication-assisted treatment options, those kinds of elements, and making them more available to whether it's the lay public or through EMS to providers out there. But it's also PSAs and educational campaigns to really take away some of the stigma and raise the awareness. But I think the challenge is really, at the end of the day, is that it's going to take all of us. We had an incredible move in this country to the 5th vital sign, right? Pain, right? So you would go to every hospital and you'd have that, that smiley face, and what was all of our, our goal was to get every patient to the smiley face. And that is a big challenge because it's a provider-patient issue as well. And we have to dampen both expectations on the doctor side or the healthcare provider side as we do also on the patient side. So it's a very robust community-wide aspect that really includes a lot of this real education on all the things that we've talked about with both in the school system, in law enforcement, but also looking at our healthcare system and even expectations that go beyond that with stakeholders that are in the community. So it's going to take all of that. Ooh, and did you hear that? It said, that's not nice. And that's what my watch just said. So I apologize for what I just said there.
So, Kerry, go ahead.
I would just add to that, I don't want to forget our colleagues in social and behavioral health, who they really have a great deal of literature, a body of work on the science related to behavior change. And it's important for all of us, important in our professions. How do you get physicians and dentists to change their practicing behavior? Just as important in the community, how do you equip them to change their behavior around opioids or Zika or any other illness? There was, in the Zika crisis, there was evidence put out by the CDC that the one thing that did change behavior was equipping women with kits to cover themselves with mosquito repellent, the mosquito nets, those kinds of things. That's the kind of actionable item that you can take to the community. And we did that during our Healthy South Texas Zika prevention, and we gave away 10,000 kits to pregnant women in South Texas. But these are actionable items, and we need that science as we want to have evidence-based interventions.
Yeah, you know, I was an ED physician at the VA hospital in Michael E. Dickey VA Medical Center in Houston, started in 1999, so 20 years now of clinical practice. And I'll tell you, I remember those early years where it was the ER doctor would get a patient who would come in with a pill bottle that said 270 pills of something, name it T3s or whatever you want to throw in there, and 6 refills. And the patient was now showing up at the emergency department on a Friday night, of course, saying, I'm out. What are you going to do? And now, 20 years later, or now 19 and a half years later, that I don't see that at all in that same emergency department setting. What I see is a real restrictive way of looking at, if you are going to prescribe narcotics or controlled substances, you are going to need to really think twice about it, whether it's a prescription drug monitoring, or you're going to be really looking at what is happening with your own prescribing practices with, you know, only 12 pills or 8 pills or 6 pills or 3 pills or no pills.
Or no pills.
And that, I think, is something that was not happening multiple
So let me
years
be
ago.
the devil's advocate.
Sure.
Okay? I won't say how far back I started clinically, but we've circled a couple of times around too many, too little, pain is the 5th vital sign, prescribe enough, don't prescribe too much. If you don't prescribe enough, the state board will come get you. If you prescribe too much, the state board is going to come get you. It's kind of a delicate place to try to be. So in a state where we have a substantial number of people who don't have third-party insurance coverage, and so the $175 for naloxone is a huge hurdle if you don't have insurance and you're writing a check, where if you don't have insurance coverage, you don't have access to clinical behavioral therapy. You don't have access to an inpatient rehab program that might help you spin down, and you do have chronic pain, whatever it is that happens to be kicking off those chronic pain receptors. So what do you tell the physicians? Many, many physicians, as this epidemic has rolled out, have simply said, I'm not going to buy any more triplicate prescriptions. You need pain pills, you'll have to find another doctor someplace. But there are people who have truly substantial chronic pain, whatever it is that's triggering that. What's our answer for those people? Here's your 3 pills, come back tomorrow, I'll give you 3 more?
Well, you know what? I guess that's directed to me because my colleagues were quiet.
Any one of you.
You know what I would say is that do your best. I mean, I think that's the first and foremost thing, is that we are recognizing this is not an easy scenario. Yet at the same time, do your best. And there are specialists that actually can do a better job of understanding and
Not if
prescribing.
I'm not insured, there aren't.
That is correct. And so Medicaid expansion is absolutely critical to this state, and we have to be thinking about that. And that's something that we have not taken in as much effort of thinking about what we need to do to ensure that every single Texan has access to health care.
Right.
I mean, that is number one. So that's a global problem in Texas, right? So that now we now go back from that. That's the desired state, perhaps for some, and maybe others disagree, but that's the desired state. We're not there. And so now what do we do when we don't have a desired state? We start to work the best we can through the system, and we have to be thinking about those populations that are most vulnerable. And I think one of the biggest challenges that we have in this whole concept of stigma is that there is this stigma that now is starting to develop when somebody says, I need something related to pain medicine. And that now we're starting to ask questions like, well, no, you don't. And we're starting to swing to the opposite direction. And I think that's another challenge. And I'll give you one last personal. My father just passed away 3 weeks ago. He had a traumatic brain injury. He fell at the house. We found him in a pool of blood. He had 2 subdural hematoma, subarachnoid hemorrhage, and a temporal bone fracture. Rushed him to the emergency department. He stayed in the hospital for 3 months. He never came home. During that period of time, he had multiple opportunities for pain medicine, and he said, no, I don't want it, I don't want it. I've heard all those things on TV about people that are gonna get addicted. So here's somebody who had a legitimate reason for getting pain medicine, and he said, no, I don't want it because I feel like I'm adding to the problem of society. That is a big challenge, and we've got to be thinking about this in a very, not theoretical way, but a pragmatic way on how this impacts people, this impacts families, this impacts neighborhoods, and this is impacting communities.
So one last quick question, perhaps. If in fact the best solution right now is finding somebody who will give you a reasonable amount of pain medication, and that clinician decides they won't prescribe it anymore, you can go on the street. But we've got a serious problem on the street. For the first time, I think, ever, we have a poisoned source. So you can go out and get your heroin or whatever, but it's now laced with fentanyl or carfentanil, and you may well die from it. Not from the overdose, not from whatever opioids you took, but from whatever the guy on the street is lacing their drugs with. So you could almost say you're being protective if you're giving patients a safe supply of medications. But it's kind of a fine line to walk on. Not an easy place to be. So we'll get Dr. Price to solve the problem and give us one of those non-narcotic, non-addictive. Okay, we've saved a few minutes for all of you. Any pressing questions for our panelists as they solve our biggest crisis?
Maybe this would have been a better question for the other speaker, but statistically speaking, are there any correlations, and I'm going to ask about a couple things, unemployment levels and access to insurance? So what you were saying, Nancy. So in states where there is greater access, you see a bigger problem or a lesser problem? In states where there is lower unemployment, bigger or less, or no relation? That's my question.
So I've seen a little bit of work that suggests that in states where you still have pain practices that have a multidisciplinary approach, so basically physicians, psychologists, and physical therapists working together, that outcomes for chronic pain patients are better. I couldn't tell you exactly how those have been defined, and I don't think there's any evidence that that's directly linked to decreases in mortality from opioid overdoses. But another kind of great tragedy that has come of all of this is that there was at one time a great tradition of these pain clinics that were truly multidisciplinary and gave people a holistic care to their chronic pain problem. And people that have high impact chronic pain, so that's maybe 9% of the population, they're essentially disabled from chronic pain. And usually it's neuropathic in nature, caused by severe diabetes, chemotherapy, or traumatic injury to the peripheral nervous system. And those resources have also gone away with the
Yes.
lack of support and reimbursement to them, which is extraordinarily sad because the evidence that they are successful is profound.
There is a very little bit of information, I think, primarily from DOD because of the multiple traumatic injuries, particularly amputations, and they all use multimodal, and they have some pretty spectacular outcomes, but it's an extraordinarily complex question.
And your question, I think, really highlights that we need better data. What are the correlations?
Right.
These deaths have been called deaths of despair. Why are they deaths of despair? Is it because of the social situations that these individuals find themselves, whether they're in rural settings with no employment or urban settings with other issues that they face? Are they deaths of poverty? But they have been called deaths of despair. But I think we need better data that really look at how people are insured, how they are able to access health care. You can imagine the problem may be greater for those with insurance who are getting prescription opioids. That may be an issue. and then they end up in a different situation. So we need better data. And I think that was one of Dr. Giroir's areas of emphasis, that we need better data.
I would agree, and I think the other thing to say is that, you know, in a county that's as large as ours, you have global county statistics, but it's hard to know where exactly, geographically speaking, within that large county, large jurisdiction, various things are happening. And that's the real challenge about data, is really thinking about where do you target your intervention. So if you're the size of Rhode Island, that's great, because Rhode Island's it's a state, and there's ways to look at that in terms of their data points. But when you're Harris County, now it starts to become harder, because you may have data that are really about the entire county, but really trying to figure out where exactly in that targeted area do we need to go for our interventions. That's a big challenge. And then you add in the social determinants factors that you threw in. I mean, that's a huge layering of data points that we need to really be thinking about.
Dr. Pettigrew.
As noted, there's a big effort. This question is for Ted Price, to develop non-opioid based painkillers, and those are the non-addictive. Can you say a bit more about the science and the mechanisms on which this is based? You've alluded to it some. And in replying to that, what is known about potential relative potency or effectiveness, and how to be effective while also avoiding the reward and addictive pathways?
Right. So the basic science of much of the work that's going on is again to target the peripheral nervous system, and I think that there is now overwhelming evidence that in people that have chronic neuropathic pain, that nociceptors, these pain-sensing neurons in the peripheral nervous system, go from being quiet to firing action potentials basically all the time. So they're always sending a signal to the central nervous system that there's some kind of threat in the immediate environment. So that's a very distressing signal to the central nervous system. And I think that and it's not as simple as like one ion channel upregulates its activity. It's actually a host of ion channels increase their activity, a whole host of other inhibitory ion channels ramp down their activity, and the system reaches this new set point where it's firing these action potentials all the time. So we've had a number of ideas in the field, like to target NaV 1.7, for instance, or NaV 1.8 in isolation, and those unfortunately have failed. So I think, or on their road to failing. So I think what the field has now started to understand through a mix of electrophysiology, RNA sequencing, and modeling is that there are networks that drive these changes, and that there are nodes within those networks that we think that we can target. So that's what one of those drugs I showed you, EFT508, does. It targets one of those nodes. And it works. It resets the neurons. They're not firing those spontaneous action potentials all the time. So I think that lots of ideas are going to be generated around this general concept, and hopefully some of them will be successful. It may not be the case that an individual mechanism fits every single neuropathic pain patient, and in fact, almost certainly it will not. So at the same time, we have to use this technology to understand how to develop biomarkers, to make predictions about who is going to respond to X, Y, or Z type of neuropathic pain medication, because without that, I think our clinical trials still end up being a mess. So there need to be lots of parallel advances, but I think that there are a lot of calls through the HEAL initiative to do exactly this kind of work, so everybody's kind of jumping in to do it. And one of the beauties of this whole sequencing revolution is that all of this data is made available to everybody. Yeah. So nobody can get away with hiding their data anymore. So everybody has access to it, and even if an individual project is not successful, it's going to generate data that somebody else can use to have a better idea. So can it avoid developing addiction? I think so, because there's no evidence that targeting the peripheral nervous system causes reward. So my hope is that most of these types of drugs will cause pain relief without causing addiction.
So please help me thank the panel for